And if at any point my slides aren't viewable or if people have questions, again, use those comments. So to start, since you can't actually see me, unfortunately, you can only see the slides, I wanted to just introduce who I am. So I'm a clinical psychologist and postdoctoral fellow at the Pediatric Anxiety Research Center. And I work mostly with kids who have anxiety and OCD. So although a lot of my examples here will be specific to children, pretty much all of this is relevant to anyone else as well, to adults. And the times when I talk about these examples, you can probably replace caregiver or parents with family members in general. So my research largely focuses on training therapists to use exposure. This is a topic I really like talking about, and I'm excited to share some of this with everyone here. And because I can't see all of you and you can't see me, I try to create something that is broadly applicable, but if there are specific areas that you want me to go in more depth about, again, just put that in the comments and I can kind of speed it along or slow down as much as is helpful. So I am affiliated with the Pediatric Anxiety Research Center at Bradley Hospital, which was started in 1999 and is devoted to the research and delivery of evidence-based treatments for kids struggling with OCD and anxiety. And so I just give this as a little context for where I'm coming from in terms of the work that I do. So at Park, we have a partial program for OCD. We have outpatient clinical services, and we do research as well. So, of course, if you're here, you probably know what OCD is, but I just wanted to start broad to make sure we're all on the same page in terms of what we're talking about. So, of course, OCD stands for obsessive compulsive disorder. And when we're talking about obsessions, we're talking about those unwanted thoughts, images, or impulses that cause anxiety or distress and also sometimes cause a not just right feeling. So sometimes we think about obsessions as falling into two categories. One is you're afraid of something bad happening. That's that harm avoidance category. And the other is that idea of incompleteness or not just right. So that one sometimes is a little harder for people to articulate, especially younger kids. But that's really that feeling of it just doesn't feel right unless I do this thing. So, and then the compulsions part is things that people do to make their worry or anxiety go down. It usually serves sort of a neutralizing function and reduces distress. And so a lot of people, there have been studies that have shown that in the general population, a lot of people might have some obsessions. That's really common. But in order to meet criteria for obsessive compulsive disorder, it means you have to have, it has to be time consuming, like take up maybe at least an hour a day, and also cause impairment and significant distress. So today I'm going to focus on talking a lot about the treatment for OCD, which is called exposure with response prevention. And so it's sort of, I put this umbrella image here because cognitive behavioral therapy, which probably many of you know of, have heard of, is that umbrella term. And it refers to that a similar type of therapy is used to treat different disorders. And for OCD, we specifically use exposure and response prevention. That's sort of the most important part or type of treatment for OCD. And so I just wanted to have this image of it to help clarify that exposure and response prevention is a cognitive behavioral treatment, but a very specific kind. So again, to get really specific about terms, when we're talking about exposures, we're talking about that process of repeatedly exposing yourself or facing those situations that cause anxiety. So that includes the thoughts, the images, the situations that make you anxious or bring up obsessions. And you do that in a gradual and supported way. So this is not where you just go right ahead and face your biggest fear or do the absolute hardest thing, but you sort of gradually find ways to approach those situations you may have been avoiding. And the response prevention part is super important for OCD, and that's the part that's saying you're not going to do the compulsive behavior once an obsession is triggered. And so it's important because with OCD, a lot of people will say, that they've tried to confront their obsessions and their anxiety just skyrockets and goes way up. But with exposure and response prevention, the really important part is making that commitment that you're not giving in, and that you're going to stop the compulsion and stay in that feared situation. So just to finish up sort of this introductory part, I want to define a few key terms that we'll revisit throughout. So the first one is accommodation. That's what I'm going to talk a lot about in terms of how families can provide support to people with OCD. And accommodation is really things that other people do to make someone else's anxiety go down. And again, I'll talk a lot more about it, but it really could be things like changing expectations, providing reassurance, or changing somebody's tasks that they have to do, or changing family's routine. Another term is bossing back, which is something that we talk about a lot when doing ERP, or exposure and response prevention, which is really just this idea of fighting OCD and choosing to refrain from rituals, even in the face of really, intense obsessions that often might mount when you're in the middle of an exposure. If you're bossing back OCD, you're saying, I'm not going to do the compulsion. Habituation I'll also talk about more, but that's that idea that when we choose not to give in to the compulsion, our anxiety will eventually come down naturally. And a hierarchy is a list of ideas we come up with for exposures. And then finally, re-exposure is something that I always want to point out to people, because sometimes there's this sense of if an exposure doesn't go as planned, or if the compulsion happens, that the exposure is ruined, when in fact there's always a chance to re-expose or kind of start over, bring up the fear again, and resist the compulsion. So hopefully this will make more sense as I get into a bit more, but I wanted to just introduce those terms so we're all on the same page. So the first thing I want to do is talk about understanding OCD. And so in this, I'm going to give an overview of some of the ways that I often talk to families about understanding OCD, how it works, how it presents. And so hopefully this is helpful, again, for people who might be suffering from OCD, as well as for clinicians. So first I'm going to talk about anxiety more broadly, since we know that anxiety underlies OCD, and so this is really the same process. So if we imagine a scenario where you go to the zoo and you see a bear, and that bear brings up this alarm system type reaction, because if you were in the wild and you encountered a bear, we would want that, right? We would want this internal alarm system to go off, for our heart to start racing, for our breathing to get shallower and faster, right? So if we saw a bear in the wild, it would set that off. And so let's imagine that for whatever reason, when you go to the zoo, you see a bear, even though it's behind a cage, it sets off that anxiety reaction, right? That alarm, that internal alarm system goes off, and you see that bear, even though it's behind the cage, you got really, really anxious and overwhelmed. You start thinking about how it might eat you or attack you, and it stands up on its hind legs, and you just can't handle staying near the bear anymore. So you run out of there. You avoid or escape the situation. And what happens is that once you get out of there, as soon as you're far enough away that you can't hear or see the bear anymore, you start to calm down and feel better. And that relief makes you think that next time you go to the zoo, you don't want to go anywhere near those bear cages, right? And basically it teaches you that, you know what, as long as I stay far, far away from the bear cage, I won't be scared. So it's really this idea of avoidance or escape that keeps that anxiety going, and we learn that we just have to keep avoiding it, and then I feel okay. So let's talk briefly about what escape and avoidance are. So one is actual escape, which I talked about here. You run out of the situation, you leave the zoo, or even just the area where the bears are. Avoidance can also cause the same result, right? And that means not going there in the first place. So again, not going to the zoo anymore. It can also mean things like doing rituals or doing compulsions to get rid of the fear. It can be distracting, closing your eyes, humming a song, putting your headphones in. And it can also mean coping through a situation. So again, if we imagine that you're in the zoo and you do go and see the bears, maybe there's sort of this more subtle avoidance where you're looking at the bear, but the whole time you're repeating to yourself, it can't get me, there's a cage there. And maybe you even are touching the cage, making sure the cage is there, saying, okay, it's fine, there's a cage. And that's your entire focus. And so you don't even notice the situation itself. So I say all this just to be really clear that escape and avoidance can look really different and can sometimes be really obvious, like running out of a zoo, and can sometimes be more subtle. And that would be things like, again, averting your gaze or sort of saying things in your head to make it less fearful. So the thing that happens over time is that it starts with the zoo. You don't want to go to the zoo. And, at first you might avoid the bear cage area. And then next thing you know, you don't want to go to the zoo at all. And then next thing you know, you don't even want to go to a game where there's a bear mascot, because that reminds you of that feeling that you had and you want to avoid it. You don't want to get that overwhelmed, anxious feeling. And then you don't even want to see Care Bears or stuffed animal bears or anything like that. And so again, what happens over time is that the more that we avoid something, the smaller the cue has to be to make us feel afraid. So it starts off as you see a giant bear behind a cage, but if you avoid and avoid and avoid, next thing you know, even the Care Bears feel threatening. So with exposure, what happens is that when you go in the situation, let's say it's the zoo, and you feel anxiety, we stop that pattern of avoidance or escape. And eventually, when that person stays in the situation, that's when they experience that thing that I described called habituation, where anxiety comes down naturally on its own over time. You can't stay at a 10 out of 10 worried forever. And so if you repeat that process and you experience habituation, you eventually learn that you can handle that anxiety. And so you learn, I don't actually have to, as long as there's not real threat, that if the bear is behind a cage, that I don't actually have to escape, leave the situation, and that even if it brings up a little bit of anxiety, my heart races, I start sweating, that I can handle that, right? So a lot of things can be learned when we allow ourselves to stay in those anxiety situations, as long as they are objectively fairly safe. So one other way I just want to describe this is a visual way that I often use, or I actually always use when I'm describing this for families, and I think helps just solidify an understanding of how anxiety and OCD function. So let's say that this is an obsession, right? And an obsession happens and anxiety starts to go up over time. So the more that you're having the obsession, you're thinking about something horrible that might happen, your anxiety goes up and up and up. And what happens is when you hit a certain point, you do a compulsion or you avoid. So in the bear situation, this is you run out of the zoo. If it's a compulsion, maybe it's something like you have to tap a certain number of times. That's going to make your anxiety drop down. But and cause quick relief. The thing that will happen though is this cycle will inevitably repeat itself. So what will happen is you'll have that obsession again or that fear again. Anxiety will go up. And you'll have learned, all I have to do is run away or do a compulsion. My anxiety goes down. But what happens is if you repeat this over and over again, you get stuck in this cycle where it feels like every time anxiety comes up, you have to either run away or do a compulsion, and that's the only way to escape it. This creates a cycle of avoidance. And this is when OCD or anxiety completely take over your life eventually, right? So to break this cycle, and again, this is really just demonstrating something we already talked about, when the moment happens when you want to run away or you want to do a compulsion, your brain is going to tell you, this is going to get so hard and overwhelming, I can't handle it. We know from experience that that's usually not true. And what really happens if you don't do the compulsion or you don't run away is the anxiety comes down on its own eventually. It could take a while, but it will get down. And that's what we call habituation. So in theory, it looks like that line. In reality, it looks more like this. So it's more like an up and down, and then you're reminded of it, and it goes up a little, and then it comes down, you're fine, it goes up again. But eventually, it gets lower. And so if you repeat this process over and over, eventually, even when you see or think about the situation, your anxiety won't even get as high. And then if you stick with it without avoiding or doing a compulsion, it will get easier. So just to sort of summarize the goals of exposure. One of the main things is to provide experience performing in anxiety-provoking situations despite feeling anxious. So, of course, we want this ultimate goal of habituation or tolerance of the anxiety to happen. We want things to make people feel less fearful. But sometimes the more important thing is just this idea of teaching people like, you can handle anxiety. You can do things even when you're feeling anxious. You can stay in the situation. Because part of the problem with that cycle of avoidance is that you learn that you can't handle feeling anxious. And so one of the things with exposure is teaching you like, actually, you can handle feeling anxious. And a nice side effect of that is that it also gets easier over time. And the other thing is that if we're learning skills like problem solving skills or emotion regulation skills, exposure gives us an opportunity to practice using those skills as well. So some things to keep in mind, and this is for clinicians and for parents and for patients as well, is that during the exposure, we want to sort of non-judgmentally pay attention to what fears are coming up, what things are happening in our body. Describe what's happening, and again, as much as possible, doing this non-judgmentally of just sort of saying like, wow, my heart is beating really fast. OCD is telling me to do this, this, and this. And also maybe describe what's actually happening. Like OCD is telling me, to do my whole tapping ritual and count and say all these things in my head. And really what's happening is that I'm just looking at like a wall in front of me, right? So sometimes it's just actually describing what's happening. And the idea is doing that without turning away, without distracting, that you're really focusing on what is the thing that's bringing up the obsession, keep your attention on it, describe it, label it, notice it, and then just have patience trusting the process that anxiety will naturally come down if you stick with it. So I also just want to briefly segue into the research about exposure. And as I highlighted before, exposure and response prevention is sort of a subcategory, a subtype of CBT. And CBT and exposure therapy, and really specifically exposure therapy, is the first line treatment for OCD, as it has the most evidence, the most studies that show that it works. And exposure specifically is the most common treatment ingredient across all of the treatment protocols. So of all the manuals that have been developed for OCD, exposure is pretty much included in all of them. And research shows that it's the main thing that drives change in symptoms. And so even if you're doing larger cognitive behavioral therapy that includes lots of different things, there's research showing that really the change happens once exposure starts, and that the more exposures that you do predicts better outcomes. So I just say this to really bring home the point that exposure is a crucial part of treatment, and that there might be other cognitive behavioral components that come up, but really we want to make sure that exposure is the core thing. I do want to give a little caveat or discussion about coping, because that's something that comes up a lot and is often a component of broader cognitive behavioral treatments. So one thing that we know is that coping strategies can be useful to reduce overall stress. So if you're generally feeling stressed and anxious, not necessarily about a really specific thing, but just feeling overwhelmed, or there's a moment that you need to get through, like maybe right before you're going to give a big talk, sometimes coping skills can be helpful, right? This might be your general relaxation strategies. If you have a busy day ahead, doing things like deep breathing, checking and noticing tension in your body might be helpful. Using strategies like cognitive restructuring, and that is really just noticing your thinking errors, noticing when you're saying things in black and white terms or expecting the worst to happen. It can be helpful to just check in on those, or using your problem-solving strategies. These are all things that, again, are part of larger cognitive behavioral treatment packages, and there's nothing inherently bad about them. They can help reduce overall stress. The problem is that when we use those things in the middle of an exposure, they can often serve as distraction, avoidance, safety signals. They can become rituals, and they can get in the way of learning through habituation. So one thing that research has shown is that if you spend more time using coping strategies, again, in exposure treatment, that leads to poorer outcomes. There is some evidence that mindfulness training, and I kind of alluded a little bit to some mindfulness strategies, which is really learning to acknowledge thoughts without reacting to them, is being used more commonly. That is different to just notice, observe, label thoughts non-judgmentally. That's different than kind of saying that, all the thoughts are wrong, logicking your way out of them, talking back to them, needing to use deep breathing to get through an exposure. It's those latter things that can sometimes interfere with learning. So just again, to be really clear, There's nothing inherently bad about coping strategies. They tend to work better when we use them outside of exposure, and we try and avoid using them in the middle of an exposure. So the next thing I want to talk about is designing effective exposures. And this is something that can be used, again, for clinicians, or if you're at home trying to work on designing your own exposures for OCD. One of the most important things about picking, like, what am I going to do? What am I going to expose myself to? Is to understand the relationship between obsessions and compulsions. And this is where doing exposure for OCD is a little more complicated, but not difficult, just complicated, than for anxiety, right? So with anxiety, we know we need to look out for avoidance, but for OCD, there's a really specific relationship between obsessions and compulsions that we want to understand before we do our exposures. So one thing that is helpful to think about is understanding what something looks like and what it's doing, what its function is. So stepping back from anxiety and OCD for a moment, if somebody waves their hand, that could have multiple, it looks the same, right? They're waving their hand, but that could have multiple functions or purposes. They could be waving their hand to greet you. They could be waving their hand to swat a fly. They could be waving their hand because they're about to give you a high five, right? And so that same motion or similar motion looks the same, but it's doing something different. Similarly, if you imagine a toddler or maybe a baby who's not really speaking yet, they start banging their spoon on the table. That same behavior could have different functions or purposes. It could be because they like to kind of play the drums. It's stimulating from a sensory standpoint. Or they could be doing it because they want to get mom's attention. They're hungry. They want her to know it. And so, again, understanding what's happening there would change what your response would be, and also is important to know, like, even though this behavior looks the same, it can be serving a different purpose. So the same thing is true with OCD. And so for one example here, something that looks the same, like washing your hands, could be, and this is often the assumed function, it could be because washing your hands reduces anxiety about germs. But another thing is that somebody might wash their hands because it gets rid of a sticky feeling, right? So to give a few more examples about this, or just kind of go more in depth with this example. So if we know what something looks like, that's a good starting point. That's probably the compulsion that we're seeing. We see somebody washing their hands. In terms of why they're washing their hands, though, there are a lot of different possibilities. So one is that somebody thinks, I'm going to get sick, and then they wash their hands. Another one might be, I feel disgusted just generally, and then they wash their hands. Then another could be something just doesn't feel right. Maybe they think someone's going to get into a car accident, and if I don't wash my hands, that will happen, right? So all of those things result in anxiety reduction. But what's important here is that it's the same compulsion, washing. It looks the same in every instance, but it might be getting rid of a different kind of obsession. And so it's important to understand how those things map onto each other, because the compulsion is the part that we resist for the response prevention part, but the obsession is what we have to activate for the exposure part. So if we're going to do an exposure with response prevention, first we have to expose ourselves to the obsession that brings up that feeling of worry, and then we have to stop ourselves from doing the compulsion. So you have to know how these things map onto each other. So here are some examples, just common examples of obsessions and compulsions. And as you might notice, there are some things that you might assume on the surface go together. Like you might think that if you have an obsession about contamination, you're going to wash your hands. Or if you have an obsession about numbers, you might do counting. But in fact, any of these can mix and match with each other. And so maybe you have a fear about somebody you love dying, and in order to prevent that, you might have to do any or multiple of these compulsions. And so it's important to understand that, so that when we're designing exposures, we know how do all these things map onto each other, because any combination is possible, really. And so once we have an understanding of how those things map onto each other, then we can create that hierarchy, that list of situations. And it can look a whole lot of different ways. There can be many iterations of it. Typically with kids, we use a scale of 0 to 10. With adults, we often use a 0 to 100 scale. With really little kids, sometimes I'll just do like these 3 faces, the happy, middle, sad face. And the symptom hierarchy can list obsessions that you're going to bring up, and it also can list compulsions that you're going to try and avoid. So there are a lot of different ways, and I'm not going to focus on hierarchy building today, but I just want to highlight again that really you want to have an understanding of how the obsessions and compulsions fit together. So you know, if I'm doing an exposure where I'm thinking about the obsession of somebody in my family dying, you know what are all the compulsions I need to make sure that I resist to go along with that. And then you can think about how to make it easier and harder. So now I want to show a video, and hopefully my media will cooperate here, of what an exposure actually looks like to make it a little more concrete. So I'm not going to show this entire video, but I'll show part of it. This is somebody who's afraid of being contaminated by germs from her dog, and she and the therapist have already mapped out her OCD in that way of mapping out all the obsessions and compulsions. They've created hierarchies. They've done other exposures. So this is sort of partially through treatment where they've agreed to the exposure, and you can actually just see what it looks like in some of the prompts that the therapist gives throughout. So.
And remember, we're going to just, for the next 40 minutes or so, handle that leash. Allow yourself to have whatever thoughts that come up or worries you have about it. You can verbalize them. Talk about whatever's in your head, okay? Why don't you pull it out of the bag? Did you put it in that bag?
No, I asked my husband to.
All right, what's your level right now?
I would say 65.
65, okay. All right. What are you thinking?
That is disgusting. I don't want to touch it.
Okay. You pull it a little closer to your body. Maybe hold it with 2 hands. What do you notice about it?
It's a lot of hair.
Hair?
And stains.
What do you think the stains are?
I don't want to think about it. I don't know. Saliva. Dog poop. It smells so bad. I'm starting to get sick.
Okay, that's all right.
Ugh.
Just let it happen. It's okay. What's that spot on it? Looks almost like it's breaking or chewed up or something. Is that?
Yeah. He chews on it.
Why don't you touch that spot? Okay. You're doing good. I know it's hard. It's good.
All right, I'm going to pause it there. I highly recommend this video, and if people are curious, I can share the link. It's obviously a bit longer, but I just want to highlight a few things that happened in that exposure, how the therapist pushed her and made it a bit harder with some of her comments and encouraging her to, touch it, have it closer to her. You can notice some of the ways in which there was subtle avoidance of, again, looking away, holding the leash further from her. And although the therapist encouraged her to make the exposure a little bit harder, she did it in a supportive way. She kind of was pretty neutral in terms of keeping her attention on it, not letting her do rituals, that response prevention part, and then also checked in a lot on her ratings as well, her fear ratings, just to get a sense of where she was and making sure she wasn't pushing too hard. So again, I find this to be a useful example. It's 8.5 minutes, so I'm not going to show the whole thing, but it's something, if people are curious, I encourage watching on YouTube, to just see a lot of the ways in which this therapist is responsive to what's happening for the client, not pushing too hard and being supportive and keeping her moving forward. So, that is just an example of what exposure looks like. And now I want to talk a bit more about how families can help. And so in addition to all the things I've talked about so far, just in terms of understanding exposure, designing exposures, there's some other specific things that I want to talk about. So the first thing is just if people are new to exposure. And again, my work is mostly with kids, so this is often things that that maybe kids think, maybe parents think on behalf of their kids. People often think, and therapists think these things as well, exposure is too distressing, I or the client must be functioning well to handle it, it'd be way too hard for the client or for me to do an exposure and resist doing compulsions. And so I think that, again, these are things that both clinicians and families and patients often think. And so hopefully throughout this, I will convince you some of the reasons that these things tend not to be true. And I think another underlying thing, though, is that exposure is something that we do with somebody and not to someone. And so it is a collaborative process, and people can probably handle more than they think. So from a clinician standpoint, to address these fears, I would say that it's not a coercive process as you saw in that video. It's a collaborative process. And I think from a patient or a family standpoint, people are typically able to do more than they think. And especially when they know they're not going to be forced or sort of bullied into doing something that's way harder than what they're willing to try. So again, hopefully throughout this, I'll convince you that these are indeed misconceptions. And if not, please let me know and I can try and clarify further. So one of the ways, though, that to help address some of those misconceptions and before jumping into actual exposures, is I want to make sure that people understand how OCD works and what it is. And this is something, again, that clinicians can explain to clients or that parents can explain, especially to younger kids. So the first thing is that OCD is a neurobehavioral problem. For younger kids, I'll often call it a brain hiccup. And sometimes I'll also kind of use a medical analogy here, both in terms of understanding what OCD is and in terms of understanding the importance of consistently doing exposures. So just like somebody with asthma or diabetes has to do things to manage their illness, so do people with OCD. And just like people with asthma or diabetes might have to take their medications in a certain way as they're prescribed, people with OCD have to keep doing exposures as prescribed. And that's really, really important. And so another thing that I always emphasize is that OCD is not anyone's fault. Just like, again, asthma and diabetes are not anyone's fault. The symptoms can wax and wane over time. And again, I already alluded to this, but once formal treatment is over, continuing medications, lifestyle changes, things like that can help to make sure that the symptoms continue to be well managed. And that this is something that might, again, wax and wane, come up over time, especially when things are maybe really stressful, symptoms might reemerge. So there's this idea of being ready, knowing that you can kind of fight back, boss back OCD when it does come up, and that there are tools to manage it. The other thing I often talk about is how common it is. So 1 or 2 in every 100 people have OCD. And so one way to think about this is that if you were to imagine Gillette Stadium were full, it has a 66,000 person capacity. That means that if the stadium were full, my context for that is like a Taylor Swift concert. If I imagine that, 660 to 1,320 people who are there cheering, singing along, would have OCD, right? So, and another way of thinking about this is like, if you go to a school that has 500 people, there are probably like 5 or 10 other kids who have OCD. So it's just helpful sometimes to have this conceptualization of, it can feel really isolating to have, obsessions and compulsions, especially when they're really intrusive, but to know that there are other people who have it. The other thing that I like to talk about is that as parents start to learn more about OCD, they sometimes start to blame themselves. And again, it's really, really important to know that it is not anyone's fault. So I just want to reiterate that again. And one of the things that I often talk about is how parents' instincts are to protect their children, right? And that's a positive thing. But what happens is that anxiety and obsessions are not actually inherently harmful or dangerous, even though they feel like it. Just like the bear behind the cage is not inherently dangerous, even though it brings up those anxiety feelings. So for kids who are predisposed to anxiety and OCD, when parents try to protect them from feeling any anxiety or distress, I like to refer to this as errors of kindness, right? Parents are looking out for them by saying, I want to protect you from harm and distress. but it's inadvertently teaching the child like that you can't handle anxiety, or that anxiety is harmful and it's not something you should feel. So it's sort of a shift, a pivot from a lot of the ways that parents are taught to be nurturing and caring, and that instead of protecting your kid from feeling any anxiety or distress, we want to validate how they're feeling, support and encourage them, and teach them to learn to tolerate distress. And so this involves saying things like, I know this is really hard, and not but and importantly, and I know you can do it, right? That like acknowledge it's hard, and I'm here for you, I'm supporting you, we're going to boss back OCD, as opposed to it's really hard, so let's run away and you can't handle it. Which again, sometimes usually happens from coming from a really caring place, but inadvertently reinforces it. So on that note of reinforcement, the things that caregivers can do that are the most helpful, the first one is just reinforce behaviors that they want to see more of, right? So if you want to see your kid trying hard things, talking to people, right, even when they're a little nervous, trying something new, that you give lots of praise and attention just for trying that. You ignore the behaviors you don't want to see. And so that means that if there is a lot of yelling or whining, or screaming when something doesn't go, or something is a little harder than expected, that you pay attention to the fact, you reinforce the fact that they approached it, and you ignore the part of the behavior that is the yelling, whining, screaming. Another thing, and I'll talk more about this later, but probably one of the most important things that caregivers can do is model the idea of approaching anxiety-provoking situations. So we often talk about this as being the exposure lifestyle, and that's one of the things that I would say is prescribed as a way of staving off OCD in the long term. And what that really means is just continually looking out for opportunities to do exposures as they come up naturally. So as a silly example of this, I was labeling my notes for this presentation earlier, and when I typed it, I had a typo, and I labeled it, OCD Noets, Noets, and I was tempted to fix it right away in sort of a perfectionistic way. And I thought to myself, you know what, I'm going to leave it. It bothers me a little bit that it says Noets instead of notes. And if I fix it right now, that's going to tell me that every time I make a tiny little mistake or typo, I have to fix it. So I'm instead going to just leave it like that. I'm going to look at it each time I look at it. It slightly bothers me, but by now it bothers me a lot less than it did before, right? And so that's an example of the exposure lifestyle where I'm just kind of on the lookout for ways to just do little mini exposures where if I have the instinct to fix it or avoid it, I lean into it instead. And so when parents adopt that mindset, that's one of the most powerful things they can do. And then the other thing, which is an exposure in itself, is for parents to learn to tolerate their child being anxious, which often brings up a lot of anxiety for parents. And so that's yet another opportunity to practice the exposure lifestyle. And then the other thing is, and this is again more geared toward kids, but I certainly encourage any of my adult clients to find a way to reward themselves as well, and home practice is certainly relevant to adults, that treatment in itself is a pretty narrow window of the day. And so to actually lead to change, it's really important that home practice is happening at least 4 or 5 days a week, ideally daily. And it means that not only are you practicing the kind of exposures that were done in session, but also things that aren't possible in the clinic. So things that are specific to the home environment or the work environment or the school environment. And ideally that should be tracked so that you can really, 1, give yourself credit, and 2, monitor your progress. And again, the rewards part is often specific to kids, where we talk about having parents reward kids each time they do their exposure. And in particular, that effort rather than results is rewarded. So it's not that you only get your reward if you resist every compulsion, but that as long as you're trying to do an exposure and trying to resist your compulsion, even in a small way, you get rewarded. And it's important that the rewards are consistent and are followed through on. And again, I certainly do encourage my adult clients to find ways to reward themselves. I know for me that sticker charts are rewarding for any sort of thing I do, even though I'm an adult. So find what works, though. That probably is not true for every adult. And then the other thing is what to do when you're stuck. And so these recommendations hold true for clinicians as well as for families. So the first thing is that sometimes people might not respond to exposure at the pace that's expected. And when that's true, usually we consider medication treatment, which I'll talk more about in a moment, as well as higher levels of care. So that's more like maybe more than once a week outpatient sessions or maybe a partial level of care. A lot of times OCD co-occurs with other disorders like depression, ADHD, autism, things like that. And so some of the recommendations for that, if those other things are getting in the way, is that one, we might want to consider medication, especially for ADHD. Sometimes other treatment modalities like dialectical behavior therapy, which is, and or trauma-focused cognitive behavioral therapy, which fall under that general CBT umbrella, might be more appropriate if there are a lot of things happening and a lot of problems to address at once. Again, sometimes social skills groups, especially for kids with autism, are appropriate, as well as higher levels of care. And similar to that, and this is sort of related to the first point, that if the improvement is really slow or if there are so many exposures that just can't happen in the office, some of the things that might be relevant to consider are, again, increasing the frequency of treatment. If it's available, doing home-based treatment can often also allow for opportunities to get coaching from a therapist through in the environment where the situations are actually coming up. Again, when family conflict is involved, family-based treatment can help. Coordinating with schools is pretty much always a useful strategy, especially if schools are willing to coordinate and collaborate on exposures. And then sometimes an issue is about insight and motivation, and sometimes before the exposure work can happen, that's where some of the other cognitive behavioral therapy treatment elements can be really important to do as like pre-exposure work to make sure, because you have to be motivated and willing to do exposures for it to be effective. So again, really briefly on medication, for moderate to severe OCD and anxiety, there's research suggesting that combining cognitive behavioral therapy, specifically exposure with response prevention, with medication called an SSRI is really the best way, the best kind of treatment that you can get and the best results. And so we don't necessarily recommend medication for everyone, but especially if there's a lot of impairment, if every exposure seems way too hard, I often talk about using medication to sort of reduce the intensity of all of the exposures, where it's not that every exposure would suddenly be really easy and doable, but it goes from everything feels like an 8, 9, 10 to all those things suddenly feel like a 5, 6, or 7, which is more the area that we can usually work in. So really, again, exposure with response prevention is the durable gold standard treatment, but if it's not enough, we can add medication, and that often helps. So the last category of things that I can't avoid talking about when we are thinking about ways that families can support people with OCD is accommodation. And so I talked about this briefly before, but accommodation is ways that family members modify behaviors to try and reduce the distress that a child or really any person experiences in a fearful situation. And so with kids, we talk about this from a parent's perspective. And as I said before, this is totally understandable, right? That a parent's instinct, their job is to protect, comfort their child and decrease distress. And so accommodation happens with virtually every family who has somebody affected by OCD, because nobody wants to see their loved ones distressed and overwhelmed. And so accommodation is the natural reaction, which is, what can I do to make you feel less distressed? The problem is that ultimately, and I'll show this visually in a moment, but although that works in the short term, in the long term, it doesn't actually let the person learn that they can handle it, right? So one reason that people accommodate is emotional, which we just talked about. Another one is functional, right? Which this comes up a lot. Like if my kid has a 2-hour morning routine that OCD tells them they need to do, but they're getting, they are running late for school, I'm running late for work, we need to get going, what can I do to cut that short, right? Maybe it's like, how can I help out with the ritual to move it along more quickly, or provide reassurance so that it ends more quickly. That's something, or, in a more anxiety example, I need to reassure my child that this thing isn't going to happen. They're going to do fine on that test because otherwise they're not going to leave the house. So that's another reason accommodation happens. And then the other common reason that accommodation happens is social, is that sometimes parents see that their child's distress or compulsions or whatever it may be will stand out. And if the parent doesn't either help them avoid the situations where they would get really distressed and overwhelmed, or make those situations easier, the fear is that my child will stand out, they'll be rejected socially. And so all of these things are really valid and common reasons why accommodation happens. But it's important, especially as we're within the exposure model, for families to encourage approach toward situations that cause anxiety and OCD to come up rather than avoidance. Because, and this is where I said I'll show visually, just like that diagram I showed before, family accommodation, those things that people do, providing reassurance, helping with rituals, allowing people out of expectations, it functions the same way as a compulsion, right? Where it provides that quick relief, but then it creates a new cycle of avoidance. So I've kind of talked about this already, but just some examples of types of accommodation that are common. So again, allowing people to avoid things, providing reassurance, changing routines, participating in rituals. The most frequent kinds, and research has shown this in several studies, but the most frequent kinds of accommodation are things like letting my child eat something different, right? Maybe OCD says, like, this thing is poisonous or likely to cause harm to me, so I let my kid have exactly what they want. This might be answering a question for my child because I know that answering that is going to be hard for them because OCD is going to say you have to answer it a certain way, so the parent answers it instead. Or things like allowing my child to sleep with the light on, or even just changing something about their sleep routine, right? And things like that are like letting your child sleep in your bed is, of course, one of the things that comes up a lot and causes a lot of impairment, but for the family and for the child typically. So again, we could spend this whole time talking about accommodation. I'm just going to kind of give a quick overview. But the other thing I do want to just say about accommodation is that nearly every parent does it. And about 60% of siblings say that they do it as well, right? It is an expected pattern. Parents' instincts to nurture and care for their child are naturally going to lead to this kind of accommodation that isn't a problem for kids who don't have anxiety and OCD, but for kids who do, it can get in the way. Most families report that they know it's not ideal. And they also, about 75% of families report that it's upsetting for them or other family members that they have to do these kind of things. Higher accommodation is also associated with higher OCD severity, which again makes sense since it's really reinforcing that OCD cycle. And it might even contribute to the development and maintenance of it and interfere with gains from exposure with response prevention. So even if you do all the exposures in the world, if parents are still making tons and tons of accommodations, OCD is not going to get completely better. So it's really a critical thing to be aware of. So how can parents help their children? One is talk about the importance of fighting worries together collaboratively. Work with the therapist to figure out a plan for gradually cutting down on accommodation, because again, it's super important to consider what I said, like one of the reasons that parents accommodate is because it can be really stressful for a parent to see their kid being anxious. And if they feel like they're contributing to that anxiety, it's much harder to cut back on those behaviors. So accommodation needs to be cut back gradually, not just to help manage the child's distress, but also to manage the parent's distress. We talked about rewarding brave behaviors, and also maybe just being less involved during times of worry is one way to help reduce that parent's distress if they're not accommodating. If there's a way for a child to sort of independently do exposures and have the parents not be involved, that's another way to sometimes handle it. One other tool that my colleague, Dr. Ilona Kagan, and I developed as part of a treatment for anxiety that can be applied to OCD as well is this LEMUR acronym. And so this is just sort of another way to remember what parents can do when they are feeling stuck and when they want to support their kid during an anxious moment. And so the steps of this are all things that we've pretty much talked about, but just to have, again, like an acronym to keep it in mind. The first thing is label what your child is feeling. label that, their anxiety is coming up, that OCD is bossing them, that they're feeling overwhelmed, and sort of say that in just, again, a neutral labeling way, identify what their emotion is. Then express empathy and compassion. This is not the same as reassurance. This is saying, like, the labeling part is, wow, I can see you look really stressed and overwhelmed right now, right? OCD must be bothering you. Expressing is, OCD is probably making it so hard for you right now, and I know how much you want to boss him back, right? And it feels really difficult. The model part is showing as a parent that you can stay calm and non-anxious even when your child is really, really stressed. So again, this dialogue might be like, it looks like OCD is bossing you around right now. I know how much OCD wants you to keep walking in and out of this doorway and how nervous it would make you to stop. And that you're showing, like, I'm calm about this, we can handle this. Even if internally, like, the dialogue is, I want to fix this right now. And then use your own skills. And so this is for parents. I think it's, again, really important for parents to be aware of, like, if they're having that internal dialogue, if I just want to fix it, I can't handle seeing my kid like this, that you sort of say to yourself, either this is an exposure, if in that moment you need to sort of find a way to relax for yourself, take a couple deep breaths, but figure out what you need to do using your own skills to stick with the situation, helping your kid. And then there's that final step of rewarding once your kid either tries to resist, or even just gets through the situation, like, even if they don't resist fully, even partially resists and acknowledges, like, that was really hard. So this is, again, we've talked about all of these things, but just one way of distilling it and making it a little more concrete, because it's always harder to remember these things when you're in the middle of a difficult moment. So the last thing I want to talk about really briefly is, I feel like we can't end a presentation right now in the era of COVID-19 without talking about how it's intersecting with OCD. So just a couple of considerations. One is that quarantine and remote schooling for some kids has really reduced OCD-related triggers and anxiety, especially like if those OCD comes up at school, then that's made it a lot easier. And for others, especially with contamination fears, it's been worse. And it's also, of course, made it harder to actually do exposures that involve school or social-related symptoms because people are quarantining. And another issue that's come up is trying to disentangle what are OCD-specific fears and what are COVID-related fears that are, probably appropriate given the circumstances. So we've seen that COVID-related concerns may increase contamination and harm concerns for some people, and that for other people, there might just generally be an appropriate elevation of contamination fears that aren't OCD-related. So one of the things, this is something we're spending a lot of time thinking about as we transition potentially, to live schooling in the coming weeks or whenever it happens, is being ready to deal with the ways in which COVID has affected OCD for a lot of people. And one thing that we're finding is that most people are able to differentiate within themselves between what are my OCD fears and what are my COVID fears, and recognize, like, what are the COVID appropriate fears where, I don't want to hang out with large groups of people, and what are the things where OCD is turning it into OCD twisty logic where all these extra precautions have to be taken. So for people who are experiencing more anxiety because of COVID that is appropriate, or maybe just not OCD, that's just general anxiety, it might be important to use anxiety management strategies more broadly, or if it is related to OCD, use exposure but at a slower pace. And anytime we're doing contamination exposures, our therapist practices are changing. Some of the things we typically do, we might not do now. Like, we're not necessarily going to go out in public and touch a whole bunch of things that could be contaminated if they genuinely have that risk. So it's really, usually it's about adhering to the guidelines, and really during an exposure, focusing in on what is the obsession and what is the fear of what could happen, and not necessarily going and doing things that are beyond the guidelines, but continuing to hold in mind what are the fears, what are the excessive rituals that you can prevent. So again, I could have spent the whole hour talking about OCD and COVID, but I just want to acknowledge a couple of those things. Happy to answer questions about it to the extent it's helpful. The last thing super quickly is that we have 2 research studies that might be of interest to some people, so I just wanted to mention them. One is a research study that we're doing in partnership with Gateway, where people can get exposure therapy from therapists there who have been trained by us in exposure. And so if people are interested, you would just call Gateway to request counseling and then ask about the BRAVE study. And this is for people ages 5 to 25 with anxiety or OCD. And then the Gateway therapists would be the ones who would sort of connect you to the study. But that's just one thing that's going on as another way to access services locally. And then the last thing is the IMPACT study, which is another study we're doing that typically includes a home-based treatment arm. Right now it's telehealth only, but this is basically a study that we're doing to compare different ways of delivering treatment for OCD and anxiety. And so I put the phone number here if this is again a treatment study for kids. This one's for kids ages 5 to 18. If people have questions or want to hear more, I'm happy to answer questions about that, or you could just call this number or visit our website, which is anxiouskids.org. And this is my email address. If people have follow-up questions and want to email me to follow up, I'm happy to answer them. So that is all. And we're right at the end of our time, but I'm happy to stick around if anyone has questions. And otherwise, thank you all so much for coming. I appreciate it.